I know how to do hypnosis, and I know it because I was taught it briefly in medical school, and I had used it a couple times in practice. And I said, let's just see if that does any good for this guy.
Welcome to this episode of the World Extreme Medicine podcast. My name is Dr. Will Duffin. And this installment is all about improvised medicine, the ad hoc equipment, methods, and techniques that enable care in the most resource-poor environments. My very special guest today is arguably the godfather of this topic. He's the author of the seminal field manual of improvised medicine and Professor of Emergency Medicine at the University of Arizona, Kenneth V. Iserson. Now, I'm not going to lie, I've got his book here in my hands, and it's a meaty tome. It's over 500 pages of the tiniest font the human eye can see, with brilliant hand-drawn diagrams. But it is stuffed to the gills with some quite remarkable and ingenious techniques that he has compiled and refined over many years as the medical director of Wilderness Search and Rescue in southern Arizona, alongside working in the full range of austere and humanitarian environments on every single continent on Earth. Of note, Ken has written a few other interesting books that are worth flicking through, including What Happens to Dead Bodies in Different Cultures, that's Death to Dust, and Demon Doctors, a profile of physician serial killers. I really enjoyed listening to Ken talk passionately and candidly about his craft. And we also explored some of the moral and ethical dilemmas that are raised when you are completely winging it and flying by the seat of your pants out in the field. So here is my conversation with Professor Kenneth Iserson. Hello, Ken. I'm so glad you could join us on the podcast all the way from Arizona.
Yes, my pleasure.
It's a fabulous compendium in my hand here, and as you can see, I've attacked it with highlighter and lots of post-it notes because it's just this incredible resource of different tricks and hacks and wizardry. And what I'd like to do, if that's okay, is just go through some of the ideas in this that have really piqued my interest and just invite you to elaborate on them. Does that sound okay?
That's fine.
So I'd like to begin with this whole kind of concept of improvised medicine. What is it and how did you get into it in the first place?
I got into it by accident, I'd say. I worked with our Wilderness Search and Rescue team for 25 years, and that includes mountains, caves, the few running rivers we have. And we'd often come across patients who needed something done, and we just didn't have the equipment, the medical equipment to do it. And so if we were going to do something, we had to figure out a way, or in some cases, the best way. One of the things that I did on the spot was the middle of the night, and I had to work the next day. And we were up in the mountains. We'd been called out. We went up in the mountains for a guy with a dislocated shoulder who had been hiking by himself. And one of our advanced nurses got there first and tried to relocate it, said he couldn't do it. And I'm thinking, okay, well, I do have sedatives in my medical pack, but if we do that, then we're going to be carrying this guy out for the next several hours, and I'd have to rush to work, and I'd be exhausted. I said, let's see if there's a better way. So I said, I know how to do hypnosis, and I know it because I was taught it briefly in medical school, and I had used it a couple times in practice. And I said, let's just see if that does any good for this guy. So I quickly tried to just hypnotize him. And one of the things was I had to get my crew back. Be quiet, just be quiet, and I induced him. And one of the things about hypnosis is you may not know whether they're really induced until you try it out. And so I did hypnotize him, and it was very quick. I mean, it's less than 3 minutes. And then using a couple fingers, I just gently pulled on his arm. It just went right in. And, we strapped it, and we said we'd carry his pack down, and he ran down the mountain. And we had to follow. And that was just one example where thinking about the situation allowed me to figure out a better way of doing it.
And your book is just full of examples like that, these elegant solutions to problems that we face in wilderness and austere environments where we don't have the resource to do the job that we would normally be doing in our usual place of work, in a normal clinic or ward, wherever that might be. And it's all about making the most of the kit you have, repurposing other kit, or sometimes using no kit. I mean, that example of using hypnosis, you didn't need any kit whatsoever. You didn't need any drugs, syringes, access. You just used the power of speech to achieve an effective anesthetic to do that procedure. That's just remarkable, isn't it?
One of the things I was taught as a medical student, what stethoscope are we supposed to use? They said, it doesn't matter what goes in your ear, it's what's between your ears that counts.
Yes.
And that's it. You have to do your thinking and have that mindset.
Yeah. And talking of the stethoscope, there's a great example in your book of where that can be used in a patient who's hard of hearing. You reverse the stethoscope. I love that. You put the stethoscope in the patient's ears, and they use that as a modified hearing aid. You speak into the diaphragm of the stethoscope. I just love that. It's a very creative way of taking a piece of medical equipment that just seems so ubiquitous and so boring and repurposing it in a whole new way. That's brilliant. Yeah,
and it generally does work. Make sure you speak the person's language, though. I've had a couple of cases where it didn't work because we were talking completely different languages. But yeah, that's a wonderful technique.
And talking of diagnostics, tell me what is direct auscultation? What happens when you don't use a stethoscope at all? Have you tried that? Does it work?
I have, and it can work. It just depends how loud the sounds are. You're not going to be hearing an S4 murmur, but you can hear intestinal sounds, you can hear lung sounds, but you have to be willing to put your ear right against the chest and explaining it to the person why you're doing it. And in fact, that's some of the sources I used for the book are going way back centuries. That's how they first did auscultation, was direct auscultation. And then they used little tubes, and eventually they got to the modern stethoscope. And now, of course, there are a lot of people are abandoning the stethoscope, but it's just going back and learning from our forebears.
Yeah, that's one thing I really love about the book is it is an exploration of the history of medicine, and you do reference that throughout. And it's interesting to see these techniques that were once used in kind of Middle Ages being revitalized and repurposed. That kind of ancient wisdom still has its place in the kind of modern medical age of technical, very high tech medicine. Tell me about this, Kenneth. US Air Force slogan features prominently in your introduction, which is "The difficult we do immediately, the impossible takes a little longer." What does that mean to you?
Don't give up. If you need to do something to help the patient, save a life, alleviate pain, figure out a way to do it, and incorporate the rest of your team in the thought effort. There have been quite a few times when, both in wilderness medicine and in situations where we just didn't have what we needed, where I asked my entire team, how do you think we can do this? And among the group, we came up with an answer. And sometimes it was the pharmacist thinking about an alternative drug. In some cases, it was one of our engineers who worked with us on search and rescue. Well, we can put together this kind of apparatus right here, and it'll do the job. So you have to be innovative. But one of the things is it necessary for the patient? You don't do it just to be dramatic. You have to, the patient actually has to need what you're doing.
Yes, indeed. I think we'll come on the second part of this conversation. I'd like to come on to some of the ethics behind this as well. But for me, one thing that really stands out is as much about it's as much about the techniques as it is about a mindset. And for me, what you're promoting here is this approach of just being able to work the problem. That's to use a phrase from NASA, not being thrown by anything and just finding a way through any problem using your imagination, your ingenuity, and it's just a really great way, I think, to approach the world as much as anything else. I really like the spirit of this book.
Well, that's what I was really trying to get through in all the cases. It's not just a list of techniques. And I should say that, back in 1938, a writer for one of the major nursing journals said, there is nothing left to improvise in medicine. Well, there are still a lot of things to improvise in all parts of medicine. And one of the important things, in the introduction, was when we work in a modern facility, physicians, especially in the more modern countries, modern healthcare facilities, we're always going to have the equipment, we're always going to have the systems in place to do what we want to do. That's the mindset. And that has been recently proved so wrong. We're not going to have an epidemic again or pandemic again. Of course, there was a worldwide pandemic with shortages of beds and shortages of medications. I've worked with our national disaster team and responded to areas after hurricanes and also after tidal waves where the hospitals were virtually destroyed, and we were just using the skeleton of the hospital to take care of patients. And these were modern, computerized facilities. There's no computers. One of the things that I kind of harp on, and my colleagues here in emergency medicine, they're aghast when I say it. They're all using these new fiber optic laryngoscopes, which I have to say are, have a few percentage points better first pass success. I said, but what happens when you're not going to have that equipment, or it fails, or you don't have the electricity, or they want to work in wilderness medicine or in less developed countries where you have to use the old laryngoscope? Are they going to be completely at sea? Oh, that'll never happen. I can't believe that response, but I hear it over and over and over again. So you have to be prepared for all these different things. Your discharge summaries, your triage, everything that's done by the computers.
Yeah.
We have to have systems.
So I really thought something as technical and high stakes as intubation, that there really wasn't another way other than using the correct equipment. But in your book, this is on page 92 of the original edition, there's incredible images. One here where you're illuminating the larynx through the cricothyroid membrane externally using a handheld torch, and you're accessing that space using a spoon that's bent in half. Have you tried this, and does it work?
I have. It does work. As one of my really experienced colleagues said, it's really dark in there.
Yeah,
So
I bet.
I mean, if you're going to use, if you're going to use that technique, you have to get as bright I think you call it torch, a flashlight, as you possibly can, and preferably in a darkened room. Uh, you bend the spoon to lift up the tongue, and it should work. What I found actually even more successful over the years, and I've done this multiple times, is blind nasal tracheal intubation. And the older anesthesiologists can still, and I can do it too, but I teach that technique. And it's phenomenally successful. Uh, and but with the fiber optics, it's gone the way of the dodo bird, it seems. And also digital intubation, which is actually uh, not that hard if you do it right. If you don't do it right, it's your hands are going to get
Yeah,
mixed up.
I can imagine
But it is successful.
smaller airways. So in pediatric patients, presumably that's a lot easier than in an adult.
No, actually, in the adults, it's fine. And the reason why is you pull the corner of the mouth back. And so you have fine access. People say, well, my fingers are too small. No, no. It works just fine.
Okay, so that's intubation. So tell me, so there's lots of other MacGyvered procedures in your book. Another example is repurposing an ET tube, an endotracheal tube, into a chest tube. How would you go about doing that?
I did it most frequently, or I did it in 3 patients within 10 minutes once at the bottom of a waterfall in a wilderness setting with our search and rescue team. 3 stupid teenagers, presumably drunk, went over the falls and were in very, very bad condition. And so I had endotracheal tubes with me, and one of my paramedic partners also had some. And we had to assume that they had pneumothoraces. We were doing what we could do to save their life. And so we used those as well as intubation to relieve whatever. I know in 2 of the cases where I put it in, uh, we did have a rush of air, and that kept the chest open.
And was that something you did in the heat of the moment? Was that an on the fly feat of improvisation? Was that something you planned and prepared for?
I had thought about it in advance. It's always helpful to think about these kinds of things in advance. But it's just like in an emergency room or in the operating room or somewhere else where you want to say, if this happens, how can I deal with it? Because then when it happens, you're all set.
So visualize success.
Visualize success and your path to success.
Yeah, I like that. Let's have a look at IV access, alternatives to IV access, IV hydration. And again, there's numerous techniques here. There's ways of making bamboo needles and also different ways of getting intraosseous access without using a traditional drill. Tell me, what's your preferred method then of getting access when you don't have the usual equipment available?
Well, I haven't actually used the bamboo. That was something that prisoners of war used in World War II. But I have used regular IV needles to gain intraosseous access in children and neonates. And where I work in third world countries, we didn't have any of the high-powered guns to put in needles. We didn't have the intraosseous needles. So we had to just use large bore IV needles. And my preferred site, which I developed, was just above the medial malleolus, just at the curve of the medial malleolus. And the reason why is that's one of the thinnest bones in the body. And I have used it multiple times, taught lots of docs how to do it, and literally saved lives. We could see it because as we were pushing the fluids through these, the kid would wake up. When we stopped, they went down, and eventually veins actually showed up, and we could start some IVs. But that's happened multiple times where I was able to save lives.
Yeah, I can imagine.
Severely dehydrated.
Yeah, the tibia is probably quite thick, isn't it? To get, say, a green needle in through there, to get through the periosteum must be quite a fight.
That's why I developed that technique, is because we had a kid, and there were three of us trying to get a needle into the middle of the tibia, which was at that time the recommended site. And no matter what we did, it wouldn't go. And with the site just above the medial malleolus, we can put it in with our hands, just a screwing technique with our hands, and it goes in fine.
What if, let me throw this one at you, Ken, you don't have any actual fluid, you've got no Hartmann's, no saline. Is there any way you can make up a safe, reasonably sterile solution that you can use from scratch? I have heard cases of people using coconut water, for example. I'm not sure that's very sensible, but what would you use as a fluid?
I don't think you're going to find much coconut water in Britain.
Can in the supermarket.
But in fact, well, and I'm not sure if the stuff from the supermarket is useful, but if you get it right from coconuts, it's been shown to be safe and effective. And I do have that in my second edition where I talk about that. But making your own IV solution has been shown to be dangerous and usually deadly. It's a very, it sounds very easy, but it's actually a very difficult technical process. And that's one of the things I did, was I looked at things that I thought would be easy to do and useful, and either tested them or investigated them. Some of those included using plaster of Paris as splints. Terrible idea. It doesn't work. No. Cauterizing wounds. You see that in all the TVs and movies. Somebody's heating up a knife and they're cauterizing. No, it completely destroys the tissue, and no, it doesn't work. Using soda bottles, plastic soda bottles as ambu bags, absolutely not. Does not work.
Yeah.
And in fact, I've looked for good ways to do improvise ambu bags, because that's really important. And there's no really good method. Some people have had limited success in models using air mattresses and things like that. But
I think that's really useful to know what doesn't work. Perhaps the most famous example that always comes up in kind of popular media is the use of the biro as to get front of neck access in difficult airway. Now, I've got to ask you, Ken, does that work? Have you ever tried it, and is it something you might advise? Obviously, if the ship really did hit the fan, but what do you think about that?
No, it's been tested repeatedly. And so you're talking about a pen when you say a biro.
I think you use the. You take out, obviously, you remove the ink, and
it does not work. And if you can test it yourself, it's really, really easy to test. All you have to do is pinch your nose closed, put it in your mouth, and see if you can breathe through it.
Yeah.
And you can't. You'll be choking in just a second.
Oh, yeah. The internal diameter is tiny, isn't it? That's right. I mean, what if you had, I suppose you need quite high flow jet oxygen for that to be effective.
That's right. And
if you've got that,
of
then you're
course
probably going to have the rest of the kit that goes with it, presumably.
Yeah. Yeah. I mean, that's pretty sophisticated stuff. The high pressure jet insufflator. And not even many emergency departments don't even have that. Even pediatric emergency departments don't have that. So that's not what you're going to be looking for. There's two other things we tested to see if they worked, and people think they would. And that's using portable radios inside a hospital if your communication system goes down, and seeing if they work. And we tested them out. We had very sophisticated ham radio operators doing this all over a modern hospital. Absolutely did not work. And that's because of the interference from the metal grid in the hospital. So that's one thing that's in a lot of disaster plans, but that doesn't work. The other thing is, and some well-known people wrote about it, and that's auscultating for fractures, with a stethoscope. And we found that it was no better than flipping a coin to find out whether they really had a fracture or didn't have a fracture. And subsequently, people have finally started reporting that. But just as with Galen, when he had things and people believed it for centuries or millennia, people believed this because of the people who had written about it. But no, it doesn't work. Well, one other thing that's in disaster plans. If you look at almost every disaster plan for a hospital in the world, is they say, if we need to evacuate the hospital, call the fire department, right? And I mean, that sounds very reasonable. You talk to the fire department, they're going to say, no, we can't do that, because it's going to take 4 people per patient wearing our equipment. It'll, from the 8th floor, it's going to take half an hour, and you have 30, 40 patients. So we developed an alternative solution that we tested in real hospitals using mattresses and sheets. And
talk me through it. So this is a vertical hospital, is that right? Tall hospital,
a vertical hospital.
Stairwells,
right.
no elevator or out of action. How do you
Right.
achieve that with mattresses and sheets? Talk me through it.
Okay, you pull mattresses off the beds, and you line the stairs of the hospital between landings. Then you can get the patient off the bed by, again, sliding their mattress around and just sliding them down the bed. They're on a sheet. You put another sheet around them. One person at the head, one person at the feet, and a third person holding onto the belt of the top person, and you slide them down the hall. We use little people to take big patients, and it was easy. Slide them down the hall onto the first mattress, whoop, right on down, and the people walk alongside the mattress and down to the landing and down, down, down. And from an 8th floor, it would take maybe 4 or 5 minutes to get them all the way downstairs. Then they just, and it's, I published a paper on it, and it was in the Southern Medical Journal, as well as describing it in Improvised Medicine.
There's always a way, always a way. Theory is one thing, and I think the most compelling examples for me are the ones where you do have real world experience of these techniques, or you've known someone. You quote lots of other colleagues in the book that have tried this and shared their experiences. But I can imagine that the opportunities to practice and battle test these techniques in real world settings must be quite limited. Is that the case? Is a lot of this quite theoretical, or how much of it have you really been able to test?
I've worked on all 7 continents, and most of it has been in third world countries. So I've gotten to plus 25 years in the field with search and rescue, and also with the disaster medical assistance team here in the U.S. So I've had a lot of opportunity myself, and then I've been in association with a lot of colleagues who've done similar types of things. One of the things that I talk, and I didn't develop all of these. In fact, I didn't develop most of these things. Most of them have been developed by others, and I adapted them, or they were developed many years ago, and I've reutilized them. One of them, which has proved to be extremely useful, is something called a ruggedized IV. And when I taught, when I was, well, what it is it's a normal IV, except that you really secure the IV really tightly. The only part that's out is just a little plastic hub, so you can put something in, and then and that's the IV in the vein. Then what you take is another IV and you stick it in there, and that's what you attach your fluid to, and you bandage it all up. And what it is for difficult evacuations from the field, or for patients who are thrashing around, including kids and other things, especially if you either had a hard time putting it in, or you figured you're going to have a hard time in the situation you're in. And I was actually doing it for the first time in Guyana, which is a less developed country, and I work at the General Hospital there, and they don't have all the resources they want. And my colleagues there were just shaking their heads, saying, "We don't need this. We don't need this." And I convinced a few to try putting this in, and then very quickly they found that, hey, it works perfectly. The person started thrashing. The superficial IV came out. All they had to do was replace that needle and put it back in, and they were golden. And that's especially true if they're giving important fluid for a very important reason, or medication through that IV. And that was developed, by the way, by the special forces in the sandboxes when they were there.
Okay, yeah. So all this innovation is happening out there, and you've just kind of concentrated it into this book. You're kind of the champion of all these different individual innovators that have created all of this. I mean, I've done a bit of experimentation myself, Ken. So my wife and I were out in Myanmar for 6 months working in a low resource setting in a neonatal unit. She's a pediatrician. I was essentially I'm a family physician, but I was her SHO. And we played around with making bubble CPAP, which was quite technical, and also I think more successfully making spacers out of bottles for salbutamol, for beta agonist delivery in asthma, and that worked quite well actually. And there's actually a section in your book on that, and also not just using bottles but also polystyrene cups work quite well. Is that right?
That's right. But
yeah,
excuse me. What I'm finding is that some of the techniques in the book are starting to become so routine that they may not belong in this book if we get a next edition. One example is lid retractors, improvised lid retractors, if you have to look at the eye. And you make them by bending the paper clip.
Yes.
But in fact, now I've seen the ophthalmologists coming down and using those instead of the very expensive formal lid retractors. They reserve their formal ones for the operating room. Things develop. Eventually, some of these improvisations become the standard.
How interesting. And I've seen in the book also paper clips being used as thudicums or kind of nasal speculae. which I think is quite nice. So one simple piece of
Right,
paper clip can have multiple different applications.
right. I also show how you can use a bent hanger.
Yeah.
Uh, is that what you call it? A hanger?
Yeah,
A metal?
clothes hanger. Yeah.
Yeah. And you can bend it and you can use that as a nasal speculum.
Brilliant. Brilliant. Ken, tell me about 3D chest x-rays. How do you get a three-dimensional kind of image in your brain from an AP and a lateral view, two chest x-rays side by side? How do you achieve that?
No, actually, you do it from two AP
Okay.
films. And what you do is you convince the radiology tech to take two films about 15 degrees apart without the person moving. Then you put them up side by side and you stare at them and you cross your eyes a little bit. Uh, I can do it in seconds. The first times you do it, it'll take a little longer and you get a 3D image in the middle. The benefit of that is if there is a foreign body or a localized pneumonia, you can tell exactly where it is in the chest in three dimensions. Um, I actually learned that at a very non third world place. Mayo Clinic in Rochester, Minnesota, used to do that routinely. I don't know if they still do for their routine chest x-rays. And you had to be able to learn to do it again in seconds as they flipped the films. A way to practice this without x-rays is to take some of those old 3D cards, which you can still find in the antique shops, and just look at them and form your own image.
So it takes a bit of practice, that one.
It takes a little
yeah,
practice, but I have a way of practicing in the book where you can
yeah.
test it out on a non-X-ray image.
I'd like to ask you, Ken, about drugs now, and some hacks or tricks that you might have on if you have a wilderness medical kit and it's limited, how you can use one class of drug for many different applications, or particular drugs that you think are very versatile in austere environments. What are your kind of top drugs that can be repurposed in many ways?
It's going to depend on what country you're in. We talked earlier about Benadryl, which is my go-to multi-purpose drug. You have to know what drugs are available and how many different uses the drug can be repurposed for. One of our problems that I see right now, and for many years in medicine, is the drug reps downgrade any drug that's generic, and they try to emphasize the use for every drug. Diazepam is a good example. We're not supposed to be using it for most of the things we used to use it for, but in fact, if you start investigating it, it has lots and lots of various uses that you could reliably use in a wilderness or third world setting. Benadryl is another one, which is a first generation antihistamine. And you might have something similar wherever you are. Some of the antipsychotics, I'll give you an example. Prochlorperazine can be used as an anesthetic, local anesthetic, as well as an antipsychotic, as an antiemetic. So, but you have to know something about.
Do you crush that and
No,
make that into a
I'm talking
solution? How
about
does that work?
All these are injectable. We're talking about injectable. Yeah.
Right.
The Valium can be used orally because it's just as effective in many cases orally. But you just have to know your own what's available where you are, and read just a little bit about the multiple uses for the particular drugs. But there's something else even more important about drugs. Well, one, uh, you can use a lot of veterinary drugs if that's all you have available.
Mm.
And I've been in situations where there were almost no drugs after a disaster, but there were some veterinary drugs. And with care, you can use the bioequivalent veterinary drug.
Mm.
Uh, Even more important is there's an expiration date on every drug. And if you look and see how they developed the expiration dates, the pharmaceutical companies, it's flipping a coin or figuring out when they want it off the shelf so you can order more. You can use expired drugs, and I have on multiple occasions. Uh, if the person is in a condition to understand, you can explain to them what you're doing and get their assent. And I mean, I've used even thrombolytics that were past their expiration.
Yeah.
And I've never had a patient say no when that was the only option.
It's great to hear your view on this, and this section, the discussion in your book is really helpful. I've always been skeptical of expiration dates, and I suspect there's always more commercial reasons for that, in kind of prompting pharmacies and clinics to be restocking regularly, so that it keeps the sales figures healthy. But the flip side is we just don't always know how much potency is lost as we go further past the expiration date for given drugs. I think some drugs lose their potency much more quickly than others. So my concern is, if it is a kind of quite a critical drug, is it really, how relaxed should we be? And I think it's a really unknown area, isn't it? But it seems to be the bottom line is that, generally speaking, the most potency is preserved for longer than we would think. Is that what you're saying?
A lot longer than we think. Yeah, the only exception is in ophthalmic medications that are put directly into the eye. We have to be careful because they can develop bacterial overgrowth without us realizing it, and that can be extremely dangerous. But other than that, all drugs can be used past their expiration date.
Yeah. I want the final kind of bit I wanted to ask you in terms of the specific techniques is around snake bites and clotting times. And I think you've got a technique for measuring that manually. Tell me, have you used this in the field, and tell me how it works?
Yeah, you draw a sample of blood from the patient, and this is to find out, one, if they need antivenin after supposedly venomous snake bite. And the second is your antivenin working? And so it's very simple. You draw a tube of blood and you tape it to the wall and you see if it clots. I mean, that's all there is. And we published a paper on that, and so it's available. We used it during my time in a sub-Saharan African country where there were a lot of snake bites. And what we found out is that where the test showed that they needed antivenin, they in fact needed antivenin. And we did not have the other sophisticated laboratory tests available.
Okay. One aspect of this, I want to move now on to the kind of ethics of improvised medicine. I think it's important to point out that the majority of these techniques are really just for use in quite extreme situations, really, where you genuinely don't have the resource or correct equipment, and there is no alternative. Is that right? This isn't something you'd necessarily be toying around with lightly. But they all require a degree of courage. And a kind of key facet of modern medicine is it's become very litigious, very guideline driven. And I think many practitioners hearing this podcast would be filled with a sense of unease. They'd be thinking, is it really something I should be doing? And how could they overcome that sense of unease if they were to find themselves in a situation needing to use the techniques you outline in the book?
Will it help the patient? And do you have an alternative that could be as good at helping the patient? I mean, it's very straightforward. If you have all your normal equipment and systems and knowledge base, go ahead and use it. But if you don't and the patient is in need, then that's the reason you're there, is to help the patient. So help them using whatever technique is available, as long as it won't do more harm than good. Mm-hmm. But in my experience, physicians in general are reluctant to use things that they haven't seen their colleagues use, that they didn't learn in residency training, that aren't run of the mill. And I don't think it's the official guidelines or protocols that are the reason. I think it's just the mindset of the physician, who generally is conservative, which isn't a bad thing. But there's a time, there's a time when you have to overcome that to benefit the patient.
You mentioned there one of the kind of key tenets of medical practice, which is first do no harm. Do you think there is a risk of certain individuals working in a low resource setting where perhaps there is less accountability, of there being overzealous heroism, whereby perhaps people are kind of playing around with these techniques, they're thinking, oh, this will make a good story, I'll give this a go. Are there times where it's perhaps best not to experiment with these techniques and just not intervene at all? How do we guard against that?
Well, if not intervening, what I tell people is not making a decision is the same as making a decision not to do something. My experience in resource poor countries is they are, if anything, more conservative than other physicians. They don't want to jump into things that they are not familiar with. Again, if the patient is in need and you have no other option, then I would recommend that people try the technique. First, do no harm. That's absolutely true. But if they're already harmed and you need to make things better, go for it.
Okay, I think that sounds like sound advice to me. Well, Ken, it's been a real pleasure hearing your words of wisdom and going through some of the key ideas in your book. I recommend anyone put yourself up a copy. It's definitely earned its place on my wilderness medicine bookshelf. I'm sure I'll be referring back to it for many years to come. So, Ken, thank you so much for your time today.
It was a pleasure talking to you, Will.
Thanks for listening to the episode. Please feel free to rate, review, and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website, where you can find more engaging content on extreme medicine webinars and indeed the collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical, and performance medicine. Thanks again.